Jessie's on board. Yep.
Yeah, Jessie's on board. Have you seen her?
Yes.
Yeah, can you hear me?
Yes.
Yes, I make you the presenter, Jessie.
Sorry.
Yeah.
So Dr. Wang Rong, is with you, right? Dr. Wang is you?
Yes.
Oh, cool. Okay. Yeah, I can see you. Yeah. Hi, Dr. Wang Rong. Good morning.
Hi, Dr. Wang Rong.
Yeah, nice to meet you.
Yeah.
Hi, good morning, everyone.
Hi.
Hey.
Nice to meet you.
Hey, we're gonna be waiting for another 3 minutes, and we can get started. I think some audience are coming in. Yeah, just wait for a few minutes.
你好。
Hey, Dr. Fisher, how's your day today? It's a long day. I'm sorry.
It's been good. It's late in the evening here, so
it's all. I think it's almost 10 p.m. in New
Yeah,
York. I'm so sorry for this time arrangement.
Oh, that's fine. That's no problem.
Okay. They are still joining the audience. Okay, David, I think we can get started. Thanks. Yeah, okay.
Yep.
So, hello, everyone. Okay. Thank you for joining today's session. I know some audience are still coming in, but for the interest of time, it's 1 minute. Let's get started. Let me just quickly kick off this adverse cardiac perfusion practice sharing session. So I'm Lydia from Adverse Life Sciences JPEG marketing team. Again, I welcome all and thank you for joining today. And I think about today's topic, how to optimize the cardiac perfusion perioperatively is always, I think, hot topic for clinicians to manage the cardiac surgical patients. So Adverse Life Science is a leading company for providing the solution of cardiac perfusion management. We are always working closely with the cardiac, surgical team, not only just provide and introduce our technology, but also help the clinicians to address those challenges and support them to continuously provide, improve the patient's outcome. So this is okay, sorry. This is today's agenda. At the beginning of the session, we'll welcome our two moderators share their expertise from the point of view of optimizing oxygenation and cardiac output by using cerebral oximetry and advanced hemodynamic monitoring implementation. So after their presentation, we would have a panel discussion session. Will be the panelists will briefly introduce their institution practice. Then we would conduct an interactive group discussion. So here, only one more thing I want to add on. So for all the audience, I'm sorry, by using this webinar platform, you are not able to unmute yourself. So please leave the questions you are interested in the group, this group chat, the chat box window, and we would try to facilitate the moderators to address all your questions. Okay, I think before we start the presentation, I would like two moderators, Dr. Fisher and Dr. Wang Rong, to give us a self-introduction. So, Dr. Wang Rong, please go ahead. Yeah. You're muted. Can you unmute yourself?
Okay, I'm
Okay,
here.
thank you. Dr. Wang Rong, you can go ahead to do the self-introduction.
Okay. Good morning, everyone. My name is Wang Rong. I'm from Beijing Anjian Hospital. I'm a chief anesthesiologist of Anjian Hospital, Capital Medical University. I have been engaged in anesthesia and orange protection for 30 years. Nice to meet everyone.
Thank you, Dr. Wang Rong. And Dr. Fisher, could you please go ahead to introduce yourself?
Sure. Well, good morning, everyone, or good evening for me. I'm calling in from New York City. So for us, it's still Thursday evening at 10 o'clock. I'm the chairman of the Department of Anesthesiology and Critical Care Medicine at Memorial Sloan Kettering Cancer Center. Before I took the job here, I was a cardiac anesthesiologist at Mount Sinai Hospital in New York City for 15 years. So I've been working very closely with cerebral oximetry since the early 2000s.
Thank you so much. Okay, we can move forward. And Dr. Fisher, you can share your slides. And let's welcome Dr. Fisher today's presentation, the cerebral oximetry for monitoring of perfusion. Okay.
All right. Does everybody see my slides now?
Yes,
Yep.
I can see a slide. Yep.
This in the presenter mode. So it should be in the presenter mode now, I hope.
Yes,
Yep,
it is.
All right, so cerebral oximetry for monitoring of perfusion. What are my thoughts on this, and what can it be used for? So the objectives of today's talk are to understand which factors influence cerebral blood flow and metabolism, understand the principles of how modern cerebral oximeters work, how they function, and most importantly, what are their strengths and what are their limitations. And then finally, I hope to convince you that you can use cerebral oximetry in your cardiac practice as a useful monitor of perfusion. So cerebral oximetry, when you look at hemodynamics or perfusion overall, it's one piece in a very large puzzle. And I think what got me very excited when Edwards Life Sciences bought the cerebral oximetry technology from CASMed and integrated it into the Edwards Hemosphere, you have all these pieces of the puzzle now in one area. It's like a one-stop shop, if you want to put it that way. So, you don't only get an idea of what's going on within the brain, but you also get an idea of what's going on systemically. What's the blood pressure, what's the cardiac output, what's the SVR. So all of these things together can help you get a good idea of what's going on with this patient's perfusion. So a lot of people who don't have a lot of experience with cerebral oximetry ask me, well, what does this number actually mean? So when you look at the screen, you're going to see a number. It might be 65, as in this example, it might be 70. What does that actually mean, and how does this number come together? Well, really what that number is, and cerebral oximetry is not arterial, it's not venous, it's something in between. It's like capillary, it's like a tissue oxygen saturation. So you can say 70% venous, 30% arterial. So you won't get something like an arterial saturation, but it's more than the mixed venous saturation that you would get from a Swan-Ganz, for example. And what it really comes together, how this number comprises, it's sort of like a product of cerebral blood flow, hemoglobin, and the oxygenation of the patient. So it gives you really good information over the cardiopulmonary status of the patient. And if you look at it from, let's say, very short time intervals, you can pretty much say that hemoglobin and the oxygenation of the patient don't change if you look at it from a beat-to-beat basis. So what it really represents is cerebral blood flow. This is an example from my own practice when I was still at Mount Sinai. This was a patient that we looked at who was in heart failure, and we started this patient on some dobutamine. You can see that's the blue arrow, and where we started it, you can see how there's a jump in the number, how the number went from being in the high 50s to 65, 66%. That was just by increasing the cardiac output. So let's look at the physiology behind cerebral oximetry first for a moment. And one of the first things that we have to understand is how does oxygen even get carried? So we're going to talk about the hemoglobin molecule first, and then we're going to talk about local cerebral blood flow and oxygen delivery and a little bit about the metabolism. So hemoglobin is a very well-studied molecule. It's a chromophore, which means it's a molecule that interacts with electromagnetic energy in the visual spectrum. That means in those wavelengths where we actually perceive color. And what's interesting about it is it has four protein subunits, 2 alpha, 2 beta, and it has 4 hemoides. And on these hemoides, this is where an oxygen molecule here can chemically bind. And what you see here is when one oxygen molecule binds to the heme part of the hemoglobin molecule, it changes its three-dimensional configuration, which means even though it's the same molecule, whether it's oxygenated or deoxygenated, because it has a structural change, a three-dimensional structural change, it interacts with visible light at different wavelengths, which means from a spectroscopic standpoint, it's actually can be seen as 2 different molecules, and we'll get into that in a moment. The other thing which is really interesting with hemoglobin is the dissociation curve. And we all learned about this in medical school, and you can see the factors that affect it. Whereas, if hyperthermia, acidosis, or hypercapnia, the curve shifts a little bit more over to the right. And if patients are hypothermic, it shifts more over to the left and binds the oxygen a little bit more. Finally, something that can't get underestimated when you're looking at cerebral oximetry is the PaCO2 of your patient. The PaCO2 is an extremely potent vasodilator for the cerebral vasculature. So you can see here on this diagram how just small amounts of change in PaCO2 can lead to dramatic changes in cerebral blood flow. So when patients become hypoventilated, in other words, their CO2 increases, you can see how the cerebral blood flow dramatically increases. On the other hand, if you hyperventilate your patients, in other words, bring the PaCO2 down, you decrease it, you can also vasoconstrict and thus lower the cerebral blood flow. This is an example that I have here. This is a patient where we went on bypass, and you can see how after initiating cardiopulmonary bypass and the perfusionist having their sweep a little bit too high, how the CO2 declined. And all we had to do now is let the CO2 rise up, ask the perfusionist to reduce the sweep, let the CO2 go from 38 back up to 50, and you can see how cerebral oximetry normalized itself again. So a question I also get asked is, how is this actually possible? How can a sensor non-invasively measure the hemoglobin concentration in cerebral tissue? Well, the first question is, how can electromagnetic energy in the light spectrum even penetrate materials such as skin and bone? And it can do this because the wavelengths that we use here are capable of penetrating the tissue, and they also are the same wavelengths that interact with the hemoglobin molecule, as you can see here on this diagram, that the foresight oximetry uses these 5 specific wavelengths, and this is something that only the foresight does. The other cerebral oximeters use 2 to 3, some maybe 4 wavelengths, but the more wavelengths you use, the better you can discriminate between oxygenated hemoglobin, desoxygenated hemoglobin, and other molecules' background tissue properties that can throw off other cerebral oximeters. So this is something which is really useful with the foresight, that it actually can give you truly an absolute value. The fundamentals of oximetry are based on Beer-Lambert's law. just to remind people here, and that's if you know what the intensity is of the light that you shine into a medium that contains a chromophore in it, you can measure the intensity that comes out, and the amount of light that gets absorbed by that chromophore is directly proportional to its concentration in that medium. And you also have to know the distance here. And that's basically how oximetry works. Pulse oximetry works on this basis that you have two wavelengths. The one wavelength you measure hemoglobin, the other oxygenated hemoglobin. And if you divide the two by each other, the length falls out of the equation, and that's why we usually give saturations as the value for oximetry and not absolute numbers. So like I talked to you about before, what is cerebral oximetry? It's a mixture somewhere between arterial and venous. It's not arterial, it's not venous, it's cerebral, it's tissue oximetry, and normal values are usually between 60 and 80%. One of the great advantages of cerebral oximetry versus pulse oximetry is that the cerebral oximeter measures tissue oxygenation, tissue saturation, which means it measures this entire tissue block and not just the pulse aspect of it, which would be the arterial part. So pulse oximeters only measure this pulse. That's why you get the arterial saturation. But the disadvantage of this is if you don't have a pulse, like when you're on the heart-lung machine, they don't work. And we all know that from our own practice, that as soon as you go on bypass, the peripheral pulse oximeter no longer works. However, the cerebral oximeter measures the entire tissue block, not just the arterial, but the capillary, the venous, and the background tissue, and works just fine either when you're on the heart-lung machine or if you have a patient who's a vasculopath or in a low-flow state. So how are we sure that we're actually measuring brain tissue oximetry and that we're not measuring something else? Well, the rule is that you usually have an emitter here, shown on this sensor here, and then there are two receivers. One is a very short distance, one is a distance further away. And as you can see over on this picture here, you have a superficial flight path of the photons and a more deeper, more profound flight path of the photons. And you can imagine if you subtract the deep from the superficial, then the superficial aspect falls out of the equation and you're measuring what's here in the cortex. Now, how do we know that this works? The great thing about cerebral oximetry is that in adults, the depth, the scalp, in other words, this amount of tissue here, is relatively constant from adult to adult. So I'm a very tall man. I'm 6'5", which is almost 2 meters if you use the metric system. And the distance from my top of my forehead here to my brain would be the same as in a 5 foot or a 1.60 woman. So you can use these adult sensors and the distance is relatively constant no matter what the height or the weight difference is between adult individuals. The distance that the photons travel here, the depth distance, is half the distance between the emitter and the detector. So with all this information that I just give you, how do we go about validating cerebral oximeters? And the gold standard of validating these cerebral oximeters is you have a patient here and you put in an A-line and you put in a jugular bulb catheter. A jugular bulb catheter is a central venous line that instead of going down towards the heart, goes up towards the base of the skull, just where the blood comes out of the sinuses. And what you do now is you keep the CO2 constant and you change the oxygen concentrations, and then you draw blood gases. You check the arterial and the venous, and you multiply the arterial times 0.03 and the venous times 0.07, and that should give you what the machine shows. And you can change the FIO and you get different readings here, as you can see on this graph. And what winds up coming about here, these are the different cerebral oximeters that are currently on the market right now. You get different readings right here. You can see the foresight here. So in other words, the value that you get when you measure the arterial and venous blood should be the same value that you read on the machine. If they are, they'll be on this line. You can see how closely they are clustered here with the foresight. This is the original foresight information that I'm showing you here from this Bickle paper. You can see the other devices such as the Invos or the Equinox. They look a lot more scattered. They're not as tight. You can see that the standard deviation here is much larger than it is with the foresight. And we actually have a device that's even a step further, which is called the Foresight Elite, or the second generation. And you can see that the standard deviation here has gotten even better. It's plus minus 3%. You can see how tight it is around here. So these devices, they certainly work. They've been proven that they can measure, and what they're measuring is really a true value. And we've understood now how we get that number. Now, what do we do if that number is seen to be decreased? Usually 60% is a cutoff value that I have seen to be a good value. Anytime you're over 60%, that means you have good cerebral oxygenation. Under 60%, you're getting borderline there. What I recommend is the first thing to do is to check a blood gas. If you have a low PaO2, you would correct the hypoxia, obviously. If you have a hemoglobin value that is under 18%, you would transfuse RBCs. And if these two components are normal, then you would go to or make the assumption that you have decreased cerebral perfusion. And cerebral perfusion can be decreased for two reasons. Either you have decreased arterial inflow, which would be in a state, for example, of low cardiac output, arterial obstruction, or hyperventilation, decreased PaCO2, or you might have a situation of venous congestion. In other words, you might have a venous cannula malplaced and the upper extremity of the patient is not draining properly, or there might be a patient position problem where the head is turned into a funny position that also impedes venous drainage. This was the paper that got us to a lot of excitement about cerebral oxygenation, and it's a paper which is already relatively old. It came out in 2007, but it taught us something, that cerebral oximetry is not just only about the brain, but it's about a lot more. Because when you look at this paper from Merkin, and you look at how effective he was and how capable he was by using this intervention protocol to optimize cerebral oximetry, you can see that what he was able to show here was that it wasn't just about brain problems. It wasn't just about identifying, let's say, delirium or strokes, but there were a lot of other things which the group that didn't have optimization of cerebral oximetry, they had higher issues with, whether that was death, whether it was prolonged ventilation, whether it was infections like mediastinitis, or whether it was dialysis. So when he made a composite outcome of this, the group that had controlled cerebral oximetry had a much, much better outcome. So it's really a marker of global perfusion, of overall well-being, even though you're looking at the brain. And this kind of makes sense because the brain is obviously one of the most important organs that we have in our body. So where is this all going? I think we can use cerebral oximetry right now as a good measurement to align itself with the other metrics that you have, with the hemisphere to show global perfusion. It shows cerebral perfusion very well. If your cerebral perfusion is well, oxygenation is well, in general, the body in itself is doing well. But the future will probably be somewhere in the realm of autoregulation that you're going to be able to measure with cerebral oximetry. And this is a great hope of mine and a lot of other people that show interest for cerebral oximetry, that when you have the ability to look at it, remember that first slide that I showed you, that if you look at a very short time interval, how really what cerebral oximetry is showing is cerebral perfusion. If you're correctly auto-regulated, if you're in that auto-regulation zone, blood pressure should not change cerebral perfusion. So you shouldn't see a difference. However, the second that you fall beneath or above that inflection point, you should start to see oximetry values change. And that's what we're hoping the future will bring, and that cerebral oximetry will be able to show on the individual patient where the blood pressure needs to be in order to optimize cerebral blood flow. There are already some of these papers out there that are promising that are showing this. They're still very much lab-based and not really ready for the clinical prime time yet. But one of the things that we have seen from this paper from Yossi is that probably the autoregulation thresholds are much higher than what we were taught in medical school. This autoregulation 50 to 150 millimeters of mercury is probably too wide, and the inflection parts are probably too far from each other. You can see here in this paper, when they were looking for lower inflection points, that a significant amount of the patients, and these were real cardiovascular patients undergoing CABG procedures, actually had their lower inflection point above 70, some of them even as high as 80 millimeters of mercury. So conclusions of my talk: low intraoperative SpO2 values correlate with poor outcome and prolonged length of stay. Looking at how we can change these interventions is still too preliminary, and a lot of work needs to be done. So I thank you very much, and I would look forward to answering any questions.
Thank you, Dr. Fisher. Very informative presentation. Oh, I hear myself echoing. Sorry. Yeah, so far we don't have any question from the audience. So is there any comments from Dr. Wang Rong or other speakers? Okay, I think if there's no questions for Dr. Fisher at this moment, we may have the further discussion in the panel session. Yeah. So let's move forward. Welcome Dr. Wang Rong to give her presentation of the anesthesia management of severe AS under the Swan-Ganz guidance. So Dr. Wang Rong will present in Chinese, and Dr. Yu will be her spontaneous translator. So Dr. Wang Rong, you can show your slides.
Okay, thank you.啊，大家早上好。那么我是来自北京安贞医院的王荣。我今天跟大家一起分享的一个病例是，一个重症的主动脉瓣狭窄的病人。我们在Swan-Ganz导管的指导下，如何做目标导向治疗
？Good morning, everyone. I'm Dr. Wang Rong. I'm from Beijing Anzhen Hospital, Capital Medical University. Today, I'll be sharing a case of anesthesia management of severe aortic stenosis under Swan-Ganz guidance.
先简单的回顾一下这个病例哈。这是一个56岁的女性，身高1.60米，体重47公斤。她主要是因为一个胸闷气短3年，然后呢加重2个月，来到了我们医院。那么她这个既往呢就是有这个病史有3年，然后呢在就是但是没有明显的这个心绞痛或者是晕厥，然后来了近2个月加重，然后呢来了之后我们也给他做了一些检查。他在4年前呢有过一个脑出血的一个病史。
This is a 56-year-old female, height 160 centimeters, weighing 47 kilos. Her main complaint was intermittent chest tightness for 3 years, and the symptoms has been aggravated for 2 months. The patient had intermittent chest tightness for 3 years, which was substernal squeezing pain, but can relieve after the rest. But the symptom aggravated for the present 2 months while the attacks happened when the patient was at rest. The patient had a previous medical history of brain tumor for 4 years ago.
简单介绍一下他的实验室的检查。实验室的检查一般情况都还好，主要就是他的那个转氨酶是有些高的，然后胆红素高，然后呢还有就是他的那个肾功能有一些异常，最主要的一个异常指标呢就是他的那个边 P 是显著增高的。
The laboratory test for her was basically fine, but she had a slightly elevated liver functional test and renal functions. The most prominent thing was that her BNP was significantly elevated.
这个是他的那个心脏超声的一个检查，主动脉窦的直径是30毫米，然后主动脉这个升主动脉的直径是50毫米，肺动脉呢是27毫米。它主要的问题呢就是一个左心的功能严重不全，那么左心的 EF 值只有23%，然后左室的枢膜径是53毫米，然后是一个主动脉瓣重度的狭窄，然后时间隔的厚度呢也是时间隔是肥厚的，时间隔是11毫米。
The main problem for her was the aortic sinus was 30 millimeters, extending aorta of 50 millimeters. Pulmonary artery was 27 millimeter. She had a significantly decreased left ventricular function of ejection fraction of 23%. She had an enlarged and diastolic internal diameter of left ventricle of 53 millimeters. Her interventricular septum was thickened of 11 millimeters.
那个超声的诊断呢，就是一个严重的主动脉瓣的狭窄，然后呢，升主动脉的这个扩张，左心功能的严重不全，这个左室功能是严重的受限的 ，EF 值只有23，然后还有一个重度的肺动脉的高压。
The echocardiogram revealed she suffered from severe aortic stenosis and generalized cardiomegaly. She had reduced left ventricular function of EF 23%. She also suffered from moderate pulmonary artery hypertension.
这是我们术中的一个情况啊，这是我们术中的一个这个麻醉的记录，包括他的心率、血氧，然后还有就是温度，这个动脉压，还有是肺动脉压，以及说我们容量，还有给药的一些管理的一些这个过程。
This is the intraoperative information about this patient. We measured her heart rate, pulse oximetry, and pulmonary artery pressure. And this chart shows the fluid control during the procedure.
那么我们手术的过程是这样的，就是术室呢是做了一个奔头加上一个3天半的成型，整个手术的时间是用了9个小时，体外的循环的时间呢一共是352分钟，阻断了呢是因为是2次阻断，然后呢阻断呢是110分钟和96分钟。这个病例呢术中是发生了一些意外，就是第一次阻断的时候呢是一个比较年轻的医生做的，然后开放了之后我们发现呢是一个这个持续性的一个室颤的过程，然后我们怀疑是这个冠状动脉的供血受了影响，所以后来又另外呢我们的这个孙立忠教授做了2次的阻断，然后所以呢阻断时间是比较长的。那么总共呢术中的这个出血呢是810毫升，然后虚血球是总共洗了1181毫升，然后输了400毫升的血浆，然后液体总量是3500毫升，不是这个是洗血球是输了810毫升，总共的出血是3点毫升， 然后呢，那个尿量呢是9200毫升。
The patient eventually received ventral and tricuspid valvuloplasty. The surgical time was 9 hours. The total CBP time was 352 minutes. The patient received cross clamping for 2 times. The first time for clamping was monitored by a junior anesthesiologist. The patient had some the patient went through ventricular fibrillation, and therefore another senior anesthesiologist take over and clamp for the second time. For the total in and outs, the patient had a blood loss of 3,000 milliliters. She received autologous blood transfusion of 810 milliliters, washed red blood cell for 1,181 milliliters, and plasma for 400 milliliters, and fluid for 3,500 milliliters. The total urine output was 9,200 milliliters.
这个是我今天主要想给大家介绍的一部分内容哈，就是关于我们的术中，死亡 gas 的应用是如何指导的临床的我们的处理。那么在我们主要监测的是这几项指标，就是心率，平均动脉压、平均肺动脉压，然后中心静脉压，还有肺毛压，然后这个心指数，体循环阻力指数、肺循环阻力指数，还有左室每分工指数，还有右心每分工指数。那么还有就是说乳酸的值。那么分了几个过程，首先是在我们麻醉诱导病人刚刚入室的时候，然后还有就是说麻醉诱导之后，然后手术开始的时候，以及说我们体外循环前，第一次阻断开放，还有就是说体外循环停止的时候，另外最后一项呢，就是在我们离室的时候。那么这里面呢，着重想给大家介绍的就是这个病人呢，刚来的时候是一个这个中度肺高压的这个患者，我们可以看到肺动脉压和主动脉压、平均动脉压压差只有14个。那么因为它是一个重症 AS 的嘛，所以呢，这个容量呢管理也是很重要的。那么它因为是一个长期的左心室代偿性的重症 AS， 所以呢，它的这个肺毛压呢水平也都是很高的。虽然我们在手术之后尽量给它再去降低，但是呢，还是说维持在一个比较高的水平。然后呢，因为它是一个这个左心肺后，虽然它室代偿了，但是它还是存在一个这个室间隔肺后的一个水平，所以呢，它的 CI 我们也要维持在一个正常的水平。这个体循环阻力和肺循环阻力呢，我们看术前呢，它是一个还是都是这个体循环阻力是接近正常的，但是肺循环阻力指数是非常高的。那么我们术后为了保证呢，它能够顺利脱机，就要尽可能的降低肺循环这个阻力的指数。那么我们还要关注的一项呢，就是这个心脏的做工的情况，就是因为对于这种重症心衰的患者来讲，心脏的过度做工肯定会导致它的一个慢慢的一个出现一个高心排性的这个心力衰竭。所以呢，我们要维护它本身就不好的一个性功能，所以我们要把这个心脏的做工呢，尽可能的去降低，达到一个让它心脏呢能够满足我们机体代谢的需求就 OK 了。但是呢，要让它尽量的得到一个休息。那么乳酸的水平呢，是因为我们这个做了2次的阻断，所以呢，在停机的时候乳酸水平是比较高的，但是经过我们的调整，它最后还是呈现了一个下降的趋势。这就是说我们如何用死亡 gas 呢来指导我们临床当中如何去用药，如何做循环和容量的管理。OK。
This is the main content for today. This chart showed how we managed anesthesia management using Swan-Ganz catheter during the during the ventral surgery. The left showed we measured the heart rate, MAP, MPAP, CVP, etc. during the operation, and the first line showed the timing of measurement. We basically measured this information during the baseline, post-induction, before surgical incision, pre-CBP, and first time of repeat, and post-CBP, and one timing after before leaving the operation room. We can see that the patient had a pretty high mean pulmonary artery pressure because she had severe pulmonary hypertension and aortic stenosis, and you can see the PCWP was pretty high, and it was consistently high during the operation. And PAWP was also high during the operation, and the patient suffered from interventricular wall thickness. You can see we need to maintain a relatively high cardiac output for the patient had relatively normal SVRI. However, the PVRI was relatively high during the operation, but our goal is to reduce this value. And the patient also had suffered from relatively we need to maintain the LVSWI for the patient because the patient suffered from a high cardiac output heart failure. We need to lower this index. Because the patient received 2 cross-clamping, we can see the lactate value increase during the operation. However, we managed to reduce the lactate value before leaving the operating room. This chart mainly showed how we use Fongan's to guide our fluid management and hemodynamics during the surgery.
这是我们术中用药的一个情况哈，就是我们在这个麻醉诱导之后，然后体外循环之前呢，我们是泵注了每分钟每公斤体重3个微克的多巴胺，然后呢，在第一次这个复跳的时候呢，我们是泵注了每分钟每公斤体重6个微克的多巴胺，还有是每分钟每公斤体重0.16个微克的去甲肾上腺素，然后每小时4.8个单位的垂体后叶素，你这里面可以给它翻译成血管加压素吧。然后那个在术后，在体外循环结束之后，一直到手术结束，然后我们是泵注的是每分钟每公斤体重的6个微克的多巴胺，还有就是0.1个微克的去甲肾上腺素和每小时3个单位的血管加压素。
For intraoperative vasoactive drugs, the patient received dopamine of 3 milligram per kilo per minute post-induction and 2 before CPB. After repeat to protamine neutralization, the patient received dopamine, norepinephrine, and vasopressin. During the protamine neutralization to the end of the surgery, the patient received dopamine of 6 milligram per kilo per minute, norepinephrine of 0.1 milligram per kilo per minute, and vasopressin for 3 units per hour.
这些是术后的一些生化指标的变化。那么 BNP 呢，在术后第1天达到了非常高的值，然后呢，其他的这个，我们可以先翻这个。
This is the post-operative information. You can see the BNP level rocket high during for post-operative day 1.
然后呢，这是一些其他的一些生化的指标，包括心肌酶，然后还有肌钙蛋白， 这些指标，包括一些肾功能的这个指标，它都是在术后呢第二天有一个急剧的升高，然后逐渐的呈一个下降的趋势。
These are other laboratory tests for her. You can see this index also rise during postoperative day 1, but gradually decreased for afterwards.
这是它的那个肝肾功能的指标。肝肾功能呢，在术后也是，开始的时候也都是有一个升高的趋势，然后呢，再慢慢的、逐渐的下降。但这个病人呢，因为他病史很长，然后病情又非常的重，所以呢，这个术后的这些波动还是有的，还是比较大的。
These are the liver functional tests and renal functional tests for her. We can see these numbers fluctuated after the surgery because the patient had a relatively long medical history and the disease condition is quite severe.
术后的转归的情况呢，他是在术后2小时40分的时候呢，他就麻醉苏醒了。然后呢，在第8天的时候做了气管的切开，第22天离开了 ICU， 第40天呢是出院。这个是因为呢，他因为还是病史太长，术后呢这个肺动脉压力一直达不到满意的结果，所以呢就没有考虑给他尽早的去脱离呼吸机，然后还是左心功能呢也不是很好，后来再加上他的肾功能指标也有一个升高的过程，所以在 ICU 的时间呢也待了很长时间，但是好在最后还是一个痊愈出院了。
The patient recovered from anesthesia after 2 hours and 40 minutes after the surgery. On postoperative day 8, she received tracheotomy. She was discharged from ICU on postoperative day 22 and discharged from hospital on postoperative day 40. The patient still had relatively high pulmonary artery pressure after the surgery. That's why she was intubated for relatively a long time. And also the patient had a pretty long medical history. Her left ventricular function was not ideal after the surgery, and she also had some renal injury after surgery. Therefore, she stayed in ICU for relatively a long time. But eventually, the patient was discharged with a satisfying prognosis.
这是术后的那个超声的检查，它的左室的输墨镜呢，已经由原来的53毫米缩小到46毫米，然后左室的 EF 值呢，由原来术前的23%升高到了46%。其他的检查呢，就是说也都是还是比较正常的。
This is the bedside echocardiogram for the patient after the surgery. You can see that the end-diastolic LVID has decreased from 53 to 46, and the left ventricular ejection fraction has increased from 23% to 46%, and the other results are relatively normal.
那后面呢，就是给大家简单的介绍一下关于主动脉瓣狭窄的一些病理生理学和它一些流行病学的一些情况。就是简单介绍一下我们中国和这个欧美国家的一些差异。那么这些呢，就是由于教授给大家做一个简单的介绍吧，谢谢。
Thank you. From this part will be a brief introduction of pathophysiology and etiology of aortic stenosis in China. We aim to introduce the differences of aortic stenosis from China and European countries. This part will be briefly introduced by me. Aortic stenosis. For the etiology part, normal adult aortic valve consists of 3 leaflets with an orifice area of 2.6 to 3.5 square centimeters and normal aortic valve index of 2 square centimeters per square meters. The etiology can be divided into congenital and acquired. For epidemiology, congenital bicuspid aortic valve malformation is the most common malformation in the general population, with an incidence of 1 to 2%, and it is the most common cause of aortic valve stenosis patients under 70 years old. And age-related degeneration is the leading cause of acquired aortic stenosis in developed countries. But rheumatism is still one of the most common causes of aortic stenosis worldwide, and the patients often suffered from aortic insufficiency as well. The symptoms include angina, syncope, and congestive heart failure. Each symptom corresponds to different expected survival. And asymptomatic aortic stenosis patients often have a better favorable prognosis. Presence of any symptom indicates a survival of less than 5 years. Severe aortic stenosis can be asymptomatic for years, and the likelihood of sudden death in this patient is quite small, even does not exceed the risk of perioperative death. For aortic stenosis patients, they experience myocardial remodeling with increased left ventricular systolic pressure and aortic systolic pressure. They experience compensatory concentric hypertrophy of left ventricle at first. However, as the disease goes on, they will experience eccentric hypertrophy, which impair systolic function of left ventricle. For hemodynamic changes, arterial pulse pressure difference was less than 50 millimeter of mercury, and they will suffer from delayed systolic pressure ascending, delayed peak, and marked ascending notch. The carotid notch of the descending branch was relatively small and even disappeared. For pulmonary artery wedge pressure, you can see a significant V wave in the waveform as the disease developed further with left atrium hypertrophy. Significant A wave is the most prominent feature. And this is the normal arterial pressure waveform. We need to know the corresponding events during the cardiac circle, and we need to understand that differences exist in the waveform between different monitoring sites. And the severity of aortic stenosis can be divided into aortic valve sclerosis, mild, moderate, and severe, using different parameters, including aortic orifice area, mean transvalvular pressure gradients, aortic orifice area index, and transvalvular peak flow velocity. For the timing of surgical intervention, any patient with aortic stenosis should be operated as soon as possible, because once the symptoms appear, the risk of sudden death increases significantly and the expected survival is short. Patients with moderate aortic stenosis should be considered for aortic valve surgery if they are undergoing other cardiac surgeries, for example, CABG surgery. Valvular junction incision or balloon valvuloplasty is usually preferred in young patients with severe AS and with valvular calcification, even asymptomatic ones. For elderly patients, valve replacement is preferred. And because irreversible left ventricular failure occurs only at the end of the disease course, surgery should not be abandoned no matter how severe patient symptoms are. In some high-risk patients who are ineligible for thoracotomy, percutaneous or transapical aortic valve replacement may be used. For perioperative management goals, we need to maintain sufficient LV preload, and these patients have poor tolerance to tachycardia, we should actively intervene on supraventricular arrhythmias and maintain sinus rhythm. We need to maintain a higher value of contractility to obtain main stroke volume, and early use of alpha agonists can effectively prevent sudden death caused by hypotension. Pulmonary artery pressure remain relatively normal for AS patients unless in the end stage, and there is no need to intervene if the patient has stable pulmonary artery resistance. For the we can consider low dose pre-medication for sedation to avoid tachycardia, and pre-external defibrillation pad in advance. We need to establish invasive blood pressure monitoring before anesthesia induction, and the induction of anesthesia should be slow to ensure hemodynamic stability. Any improper use of medications that cause myocardial depression, blood pressure drop, tachycardia, arrhythmias will deteriorate the circulation. And we should always administer with caution of nitroglycerin in patients with signs and symptoms of myocardial ischemia, as it lowers preload and blood pressure. And we can monitor the patient using pulmonary artery catheters, TEE, and take care of myocardial protection. In the absence of preoperative cardiac dysfunction or coronary heart disease, valve replacement should be reduce the afterload, and inotropic medications is not often needed after CPB. And that's all. Thank you for listening.
Thank you, Dr. Wang Rong, and thank you, Dr. Yu. Very nice and informative, comprehensive presentation. So we still have a few minutes left before we move on to the panel discussion. Dr. Fisher, we got the 2 questions from audience about your topic. Have you seen the questions? The first question is there any impact on STO2 where sedative or non-sedative time? And the same way, non-sedative to sedative time and impact STO2? That's the first question.
Yeah, when this was first coming out, like in the early 2000s, some people thought that you would see a change, but you don't really. And it kind of makes sense because the brain, whether you're awake or asleep, the oxygen consumption is the same. So you actually don't really see a change whether they're awake or whether they're anesthetized. So that doesn't change. Where you will see a drop is if somebody has like epilepsy. So if you break epilepsy, then you actually do see the cerebral oxygenation increase. So that would be the answer to that one. And then Dr. Kapoor has an interesting question where he asks, are there studies that look at cerebral oximetry of the brain and hyperperfusion? Yeah, that's always been an interesting question. We've always focused on hypoperfusion, what happens when the cerebral oxygenation value is too low and what happens when it's too high. There's nothing that I'm aware of as far as too high. Is there an upper limit to it? So what happens if it goes up to 90 or anything higher like that? There's nothing that I'm aware of as far as that's concerned. What we have been seeing, though, is in the autoregulation realm, patients who exceed their upper limit of autoregulation, they have a tendency to have more delirium, which also makes sense because if you perfuse the brain too much, you're going to get edema, and that will change things. So those patients do have a higher association with delirium.
Thank you, Dr. Fisher, for addressing those questions. Okay, I think we can move forward to go next session, panel discussion. Okay.
Yep. So I'll just do a brief introduction on the panel discussion. So in this panel discussion, we have 3 panelists, Dr. Gao Ji, Dr. Wang Tao, and also Dr. Mutita. So how this session will proceed is the panelists will present their hospital practices as to how they manage cardiac perfusion. And of course, This will be moderated by our esteemed speaker, Dr. Fisher and Dr. Wang Rong, who will also ask questions on their practices and provide their thoughts on their practices. This will be a group discussion sessions. So once the group discussion session is finished, please feel free to ask any question and answer. So without further ado, just allow me to do a brief introduction on the panelists. Dr. Gao Ji, we have the first presenter, Dr. Gao Ji. He's from the Northern Jiangsu People's Hospital, and then followed by Dr. Wang Tao from Tianjin Chest Hospital, and then, of course, followed by Dr. Mutita from Chulalongkorn Hospital in Thailand. So without further ado, I present the floor to you, Dr. Gao Ji. Yep, Dr. Gao Ji, the floor is yours.
Okay, hello everybody.
Hello.
Hey, Dr. Gao. Please share your slides.
Okay, wait.
Yeah, we cannot see your slides.
Yep, we can see.
Okay, now, can you hear me? It's okay?
Yes, please go ahead.
Yep, please proceed. Yep.
Okay. My title is Near Infrared Spectroscopy for Monitoring Cerebral Oxygen Saturation. First definition. Near infrared spectroscopy is Near-infrared spectroscopy is used to obtain continuous, non-invasive measurements of regional oxygen saturation in real time, which may aid in monitoring oxygen metabolism in the brain during the ischemia reperfusion process. Measurements of RSO2 are considered to reflect the balance between cerebral oxygen delivery and consumption in the area of the brain, located beneath the device. The second part, recent research. The title is Association between Postoperative Delirium and Postoperative Cerebral Oxygen Desaturation in Older Patients After Cardiac Surgery, which was published in British Journal of Anesthesiology. We can see the methods. Patients aged 70 years and older scheduled for on-pump cardiac surgery were included. Baseline RSO2 was measured 1 day before surgery. Throughout surgery and after ICU admission, RSO2 was monitored continuously up to 72 hours after operation. Association with delirium was evaluated with unadjusted analysis and multivariable logistic regression. Results. Intraoperative RSO2 was not significantly associated with POD. The lowest postoperative RSO2 was lower in patients who became delirious. The absolute and relative postoperative RSO2 decreases were more marked in patients with POD compared with patients without POD. Conclusion is POD in older patients undergoing cardiac surgery is associated with absolute decreases in postoperative RSO2. Third part is our research progress. Our first research, the title is Analysis of Risk Factors for Postoperative Delirium in Frail Elderly Patients After Cardiac Surgery. 130 patients aged 65 years and older scheduled for cardiac surgery with CPB were included in this observational study. Patients were assessed preoperatively according to the frailty index scale and were divided into frailty group, pre-frailty group, and non-frailty group. Clinical information such as gender, age, MMSE score, past medical history, hemoglobin, and operation time were recorded. NIRS was used to monitor RSO2, and risk factors were analyzed by logistic regression. The ROC curve was drawn to evaluate the occurrence of the related risk factors. The conclusion is frail index score. The greatest intraoperative RSO2 decreased from the baseline value during CPB. the lowest intraoperative RSO2 value during CPV, and operation time were independent risk factors for the development of POD in elderly frail patients after cardiac surgery. And FI score and RSO2 decrease from the baseline value are available to predict the occurrence of POD in this kind of patients. Our second research title is Association between Postoperative Deuterium and Tissue Oxygen Saturation in Frail Patients Undergoing Cardiac Surgery. 150 frail patients aged 42 years and older scheduled for on-pump cardiac surgery were included in this observational study. The patients were divided into POD group and non-POD group according to whether POD occurred 7 days after this surgery. Cerebral oxygen saturation, renal oxygen saturation, and brachioradialis oxygen saturation and other indicators were recorded. Pearson correlation was used to analyze the relationship between tissue oxygen saturation and the incidence of POD. Conclusion is the incidence of postoperative deuterium increased by 2.9% for every 1% increase in the greatest cerebral oxygen saturation decrease from the baseline value during cardiac surgery in frail patients. However, renal oxygen saturation and brachioradialis oxygen saturation had no correlation with POD. The last part is future perspectives. First, I want to say large multi-center studies are needed to confirm the association between postoperative cerebral desaturation and POD after cardiac surgery. Most of the studies on cerebral oxygen are observational, so no causal link between POD and cerebral desaturations can be inferred. In addition to cerebral oxygen, the oxygen saturation of other tissues like renal, muscle, and spine also deserves further investigation. That's all. Thanks for listening.
All right, thanks, Dr. Gaoji. For the audience, if you have any questions, please feel free to type in the session. In the interest of time, we'll proceed to Dr. Wang Tao, and then after all the three presentations have finished, then of course we invite Dr. Fisher and Dr. Wang Rong to provide your input and also questions as well. So next up, Dr. Wang Tao.
Okay, can you hear me, David?
Yes, we can.
Sorry.
Yep, we can see your screen.
Okay, good evening, Professor Fisher, and good afternoon, Dr. Wang Rong, and all the audience on the line. It's my honor to be here to share experience in retinal tissue oxygen saturation monitoring in off-pump coronary artery bypass surgery in Tianjin Chest Hospital. My name is Wang Tao from anesthesia department, and in the 1990s, pulmonary artery catheter was first introduced into clinical practice in our department with the aid of PAC. The hemodynamic changes during cardiac surgery were unmasked, and later on, transesophageal echocardiography was adopted as a routine monitoring modality during cardiac surgery. About 5 years ago, oxygenation monitoring was firstly used in some specific surgeries. From the very beginning, cerebral oxygen saturation was first used in aortic arch surgery, which require dipole hypothermia cardiac arrest and cerebral perfusion in order to reduce postoperative complication. After that, cerebral oxygen saturation monitoring was applied to complicated pediatric surgeries in our department. Last year, we conducted a single-center random controlled trial in our hospital, trying to elucidate whether cerebral oxygen saturation monitoring and individualized intervention can improve outcome of patients after off-pump CABG. And there are more than 3,000 off-pump cabbage surgeries in our center every year due to the complication rate postoperatively and the beneficial effects of tissue oxygen saturation monitoring manifested by other researchers. We seek to find out whether cerebral combined with muscle oxygen saturation monitoring can optimize tissue perfusion and improve the outcome of the patient. As illustrated by the picture here, we put two sensors on the forehead of the patient and one sensor on the forearm of the brachioradialis. Besides tissue oxygen saturation monitoring, hemodynamic management was guided by lytical, inotrope or vasoactive agents were administered based on hemodynamic changes in order to maintain oxygen saturation within the basal level. We hypothesize that optimization of tissue oxygenation guided by hemodynamic monitoring will improve outcome after off-pump cabbage surgery in this trial. That's all. Thank you.
David, sorry, you are muted. David, you mute yourself.
Oh, sorry. Didn't realize. Yeah, thanks, Dr. Wang Tao. That was a very great session. So next up, we have Dr. Mutita. Dr. Mutita, the floor is yours. Thanks. Dr. Mutita, you are muted. Sorry.
Good morning, everyone. This is my honor to join this sharing experience conference. This is nice.
Yes, we can.
Okay. Slide ไม่ขึ้นในแชท
Yeah, we can see the pointer and the slides. Yeah.
จอมันไม่เหมือนเดิมต้องทำยังไงแชร์อย่างอันนี้แชร์อย่างแชร์แล้วขึ้นแล้วโอเค In our center, I work as a cardiac anesthesiologist at King Chulalongkorn Memorial Hospital in Thailand. We mainly use the continuous cardiac output monitoring used intraoperatively and often continue the monitoring in postoperative care. Most common indication is poor cardiac function, decompensated heart failure such as dilated cardiomyopathy or ischemic cardiomyopathy, which usually presented with low ejection fraction, especially when the ejection fraction is below 35%. It can help evaluate the effectiveness of cardiac function, represented by cardiac output and cardiac index. In our center, we take care of some heart transplantation case, about 10 to 15 per year. So heart transplantation is also indicated for this monitoring too. The second most common use is for multiple valve pathology. Because our center is classified as tertiary care and medical school hospital, so most of our patients is severe cases presented with decompensated heart failure. This monitoring helps differentiate the functions between right and left-sided heart. We can calculate systemic vascular resistance and pulmonary vascular resistance based on parameters from the monitoring to guide us for appropriate management and plan for further ventricular support. Moreover, when we found the complicated cardiogenic shock, especially refractory shock with high inotropic or vasopressor dosage, or the patients received intra-aortic balloon pump or other cardiac assisted device. We use the monitoring to indicate states of shock by using preload assessment and fluid responsiveness, guiding patients' volume status and response to therapies. And the last indication is to measure and monitor continuous mixed venous oxygen saturation to identify and balance between oxygen supply and tissue oxygen extraction when we manage vasodilatory shock or vasoplegic syndrome coming after cardiac surgery. Here in our center, we found a lot of mixed shock after cardiac surgery. So we use a lot of mixed venous oxygen saturation too. Thank you.
Right. Yeah. Thanks, Dr. Mutita. Yeah. So that was a very great session. So now the floor is up for discussion. Maybe we give the honor to Dr. Fisher. Do you have any questions or thoughts on either of the three presentations?
Dr. Fisher, sorry, you're muted.
No, I thought great presentations, useful, utilization of the monitoring techniques. What we saw with the cerebral oximetry is very similar to my own experience, is that, the cerebral oximetry can really define sick patients and who will do worse. The interesting studies, though, that haven't been done is if you can intervene when you've identified these patients and you optimize them by, let's say, improving cardiac output or oxygenation or whatever, if you can then improve outcomes. That's really the interesting aspect of it. But, all of these monitoring techniques are without doubt very beneficial and useful for the patient.
So Dr. Wang, is any comments on the panelist contents? Okay.
Okay.
Dr. Yu.
Dr. Yu.
Hi, Dr. Yu, you want to say something?
Dr. Yu.
Yeah, thank you. Very informative presentations. I have a little question for Dr. Wang Tao. I'm really curious about if there's any research made comparing the cerebral plasmatic oximetry monitoring. Is it better than the cerebral oximetry alone? Is there any clinical trials about comparing these techniques?
Thank you, Dr. Yu, for your question. In your opinion, or my center's experience, compare the traditional monitoring with the cerebral or tissue oxygenation monitoring definitely can improve the outcome of the patients. From our clinical trial, the outcome can show us the trend of better outcomes of the patient. We didn't finish our trial, so we can't say too much about that.
Yeah, I understand.
Sorry.
I am just curious about what kind of particular outcomes are you focusing on, or just the general prognosis of the patients?
We have several targets. We have the primary outcome as the death of the patient, and the secondary outcomes such as some complications, including postoperative delirium, renal failure, cardiac injury, and so on. We have several indicators to observe.
Thank you very much.
So if any questions for the panelists or the moderators, and please feel free to type in question into our chat box. So I have a question actually I want to address for Dr. Fisher. So in your institution, what's like the standard practice, like using cerebral oximetry, combine the hemodynamic monitoring to improve the patient's cardiac perfusion status? Do you have any insight about that?
Yeah, so we use cerebral oximetry as well as BIS monitoring on all of our patients for neuromonitoring. And all of our cardiac cases, both on pump and off, would receive cerebral oximetry and BIS monitoring. And what the cerebral oximeter tells you, and this is why I find it such a great monitor, is that it shows you both oxygenation and cardiac output. And so when you come off the heart-lung machine, if the cerebral oximeter value is in an acceptable range, I know that everything is fine with the patient. If something isn't, then something is wrong. And I just look, and I will keep going and going and going, and I will try to differentiate what's wrong with the patient, why the cerebral oxygenation isn't great, right? And I've seen multiple reasons. I remember once we did a case and the surgeon forgot to take off the SVC tie. You know, when you have bi-cable cannulation, they put ties so it doesn't leak in, and he just forgot to take it off. So the drainage wasn't ideal, right? And the cerebral sat was low, and I kept complaining about it, and he said, everything looks fine in the field, and then all of a sudden he realized that he took it off quick, and then you could see the cerebral oximetry value normalized immediately. If I see that patients have low cerebral saturations and everything else, you can see if the cardiac output's not adequate, if it's just not meeting it, where it should be. So all of that can help guide, because then you have TE. And like I said at the beginning of my talk, there's no single monitor that can tell you everything. It's a puzzle. And you have to put the different pieces together before you see the picture, right? So, it's what makes cardiac anesthesia difficult, that you have to be able to put all the pieces together to see the correct image, right? So you have TE, you have the information, the hemodynamic monitoring from a Swan-Ganz, for example, from the cerebral oximeter. All of this information has to come together and make sense and show you a picture of what's wrong with the patient before you can intervene.
So in your institution, the practice, I assume there are some maybe different protocols to get the different kinds of the implementation, right? So thank you for sharing. I think the audience you'd be very interested about what's your institution's protocols look like.
I mean, what we've seen in our institution, we've actually probably been using less Swan-Ganz catheters than when I first started. That's sort of been reduced, and other forms of monitoring have maybe come up more, like the flow track, right?
Yep.
The cerebral oximeter is very popular. So some of it is institutional bias, and I don't think there's a right or a wrong way. A lot of it just has to do with what the individual institutional culture is.
Okay.
And any monitor that you use often, you'll know its strengths and its limitations. Like, there's nothing worse if somebody has no experience with the Swan-Ganz catheter, and then you put it in once every 2 years. It will probably do more harm than it will do benefit. Where people who use it on a daily basis, they can read and interpret the data much better than somebody who uses it once off. It's the same with the cerebral oximeter. It's the same with any monitor.
Yeah, definitely. Yeah, I think individual care is even more important, right? In the most of the case. I think Dr. Mutita raised your hands. Okay, please go ahead, Dr. Mutita. Any question?
Yes, I have a question. I have two questions. for Dr. Fisher. Firstly, I very appreciate your slides. It's excellent lecture. The first question, how long you use the cerebral oximetry after the patient leave the operative room into the intensive care? How long?
Not long enough. In routine clinical practice, we only use it intraoperatively. But I have done studies, so, in the realm of a study protocol where we've kept it on for 24 hours or until the patient was extubated. Because, the best monitor for any type of cerebral perfusion is an awake, interacting patient. That's always the best, right? But we have had some studies, and the interesting thing is that you will see a lot of desaturations even in the ICU.
Yes.
It's foolish for us anesthesiologists to think, and often we think that only bad things happen in the OR, and once the patient is in the ICU, it's like, oh, okay, it's done, right? It's all good now. It's a continuum, right? It's a process. In the United States, I tell my residents often that surgery is like baseball. I don't know if you guys know baseball very well, but there are 4 bases, and then you go home, right? The home plate. And you only can score runs and win the game if you get home. You leave players on the bases, you get nothing from it. So OR is first base, ICU second base, floor third base, and then the patient goes home. Because ultimately what patients want is they want to go home. Nobody wants to be operated on, right? The goal for surgery is always to go home and have improved quality of life than what you had before the operation.
Okay, that's very impressive. The second question is, I found that when we use cerebral oximetry intraoperatively, everything going very well. And after that, after leave the operative room, the patient still have posterior circulation stroke. Do you have experience about this kind of post-operative stroke? And do you have any tips or trick to improve this problem?
So the first thing, and this is why I always said in my slides, you have to know the strengths and limitation of any monitoring device. There are 2 types of strokes that you can get. One stroke is embolic, so you shoot something up into the brain, and the other type of stroke is a low flow. We call this a watershed distribution stroke in English. It means that there's not enough perfusion in the brain, and there are areas in the brain which we call watershed. That's the last areas, like the last meadows that get water. In the brain, you have that as well. Those are basically those regions that are in between the big cerebral arteries, the anterior, the posterior, the middle cerebral artery. The cerebral oximeter is really, really good at picking up low flow states, but it will not pick up embolic strokes. Because remember I showed you the diagram with the photons that fly there? The cerebral oximeter examines about 1 cubic millimeter. That's really tiny of tissue, right? And what you're doing is you're extrapolating that the conditions in that 1 cubic millimeter, that tiny little bit of cerebral tissue that you're measuring, is the same for all the brain. Now, in low flow states, in global malperfusion states, that will be true. But in a situation where you have a stroke, and remember, most strokes will go in cardiac surgery, will come from the heart, they'll go up the right carotid, and they'll go somewhere into the middle cerebral artery distribution. You're not measuring there with the cerebral oximetry. And what you talked about was a posterior circulation stroke. You're definitely not measuring there. You're measuring somewhere here between the frontal, and you measure here on the forehead, somewhere between the frontal and the parietal lobes. right, in that watershed distribution area. So if the embolic stroke doesn't happen exactly where you're measuring, you won't pick it up. So that's the weakness, if you want to put it that way, of this monitoring technique. It's not made for embolic stroke. It's very good for watershed stroke. So that's why you can have completely normal oximetry readings and the patient can still have a stroke postoperatively, unfortunately.
Thank you very much.
Okay, we got another question. Oh, go ahead, David. Sorry.
Go ahead. Yeah, sorry, Nida. Yeah, we have one more question from China.麻醉医学会.
It's from Taiwan. I
Taiwan.
suppose.
Sorry.
Yeah.
Please feel free to unmute yourself and ask the question. Thanks.
Okay. I have two questions. I'm Dr. Zhou from Taiwan. I'm the president of Taiwan Society of Anesthesiologists. Thank you for offer this chance to join this meeting. I have two questions for Dr. Fisher. Can you hear me?
Yes, I hear you well, yes.
The first one is how to manage the patients with very low baseline cerebral oximeter value before open heart surgery. What's your comment for differential diagnosis for this kind of patient? How can you do?
Yeah, it's an excellent question, and the interesting thing is, and this is where absolute oximetry really does help, and where the Foresight technology really separates itself from the other oximeters. When you look at like the INVOS technology, which only uses 2 wavelengths, as opposed to 5, like the cerebral oximeter that Edwards has, the standard deviation is 10%. So if you think that a population is 2 standard deviations, is 95% of the population, that gives you a 40% spread. So there will be a significant amount of patients who will have, let's say the middle average is 65. If you go 40, right, 20 in both ways, that means there's going to be some patients who will be well under 50, right? And they're perfectly normal. It's just because 2 wavelengths is not enough to resorb. So that's a problem with some of the other technologies that other brands use, and there's really not much that you can do there. What the companies that make these cerebral oximeters say is you have to get a baseline and then stay within 20% of that baseline. Now, I don't know what that really means, because what's the percentage? 20%, 30%? I don't know. Where's the data that supports that? And the danger is the lower the value is, the less is your percentage, right? So somebody who has a very high baseline, let's say you have a baseline of 85%, if you want to say 20%, you can go much lower, right? You can go 16%. Whereas if somebody has 40% and you want 20%, you can only go drop 8. So a lot of these things don't make sense. Now, the Foresight, on the other hand, you saw has a plus minus 3% accuracy. That's like a pulse oximeter. That's really, really good and really, really close, right? So if somebody has a low baseline, let's say under 60% with the Foresight, that would be concerning to me, that patient has a problem, right? And that would be either the patient has a pulmonary problem and is hypoxic, so a blood gas would be interesting to see if that patient has, baseline hypoxia. Is the patient severely anemic? Maybe the patient starts off with a hemoglobin of only 7-8% for whatever reason. Or is the patient's cardiac output really, really low? Like we would see that at Mount Sinai in heart failure patients. Heart failure patients, that were only, just getting by with maybe, a cardiac index of 1.7, 1.8, it's just like creeping by. they often would have cerebral saturation values under 60%. And like that slide I showed you, if you started them on a little bit of an inotrope, you could just watch the cardiac output go up and help them. So if the baseline is low with the foresight, with the elite technology, there's a problem there, which I would go and look for.
Thank you.
Okay, great. Thank you, everyone. I think for the interest of the time, we're gonna ask Professor Fisher and Professor Wang Rong to give us a quick wrap up the session. We may have take 1 minute. Okay, please go ahead, Dr. Fisher.
Oh, well, thank you all for coming. I mean, I'm honored to be invited. I wish it were 10 in the morning and not 10 at night, or actually now it's 11:30 at night for me in New York. It's a lot easier to give these presentations during the day, but thank you so much. It's an honor and a privilege. And, really, cerebral oximetry has been a very important part of my career and also of my practice. I'm somebody who doesn't just preach it, but I also use it. And I do really believe that understanding this technology can help improve patient outcomes. So thank you all for listening.
Thank you so much. And Dr. Wang Rong, please.
首先感谢这个爱德华公司的邀请哈，然后我觉得是这样的，就像刚才 Dr. Fisher 说的哈，就是没有任何的一项监测设备它是完善的，或者说尽善尽美的。就是说我们每个监测呢，它有它的优势，也有它的局限性。所以我们其实在临床工作中呢，大多数是一起去用，然后互相参考。另外就是每一个监测设备其实给我们的都是一个比较片面的一个东西，就是它没有说它给你的是一个指标，而我们如何去用，然后如何去判断，需要根据我们的临床经验、病人的个体差异、手术的当中的情况去做选择性的分析，然后做出自己的判断，才能够把所有的监测用到最好，然后达到它最大的效果。好，谢谢大家。
Dr. Yu, are you going to translate briefly?
Yeah.
Okay.
Thanks for the invitation from Edwards. As Dr. Fisher has mentioned before, that no single monitoring is perfect for a single patient. So in the clinical practice, we often use multiple monitoring, and they can be referenced for each other. And utilization of this monitoring should based on individual conditions and based on our clinical experience, and we need to analyze this information in a comprehensive way to monitoring to guide our clinical practice. Thank you.
Thank you so much. Sorry for being running a bit behind the schedule, and thank you for everyone. And after this session, we'll have a post survey we'll send to all the audience, and you're welcome to provide any feedbacks about the session. Okay, thank you so much.
Provide you the link for the recording. Yeah, thanks.
Thank you for your time. Thank you, Dr. Fisher. Thank you, Wang Rong. Have a good night. It's very late. Thank you. Have a good day. Yeah.
Have a good day. Get back to the OR, everybody else.
Thank you. Good morning.
Bye.
Thank you, Lydia David. Appreciate it. Have a great morning.
You're welcome. You're
Dr.
welcome.
Fisher.
Thank you, Maru. Thank you so much for your support from US team.